Okay, so as you know, like this time in exam there were around 6 to 8 questions from hematology. So this is like a very important topic. So I thought to start with this topic because in this topic you need solid concepts. So without wasting your time, we'll start with hematology. If I say by seeing this report, we call this CBC report. CBC means complete blood count. This is like a part of a routine investigation and this give you a lot of information. So we should interpret a lot of things by the CBC report. Like we can see hemoglobin, we can see RBC count, we can see MCV. So today I'll teach you how to approach a patient by seeing the CBC report. Okay, so see, with the basic thing, if I say first we have hematopoietic stem cell. HSC means hematopoietic stem cell. If I say hematopoietic stem cells, we divide this hematopoietic stem cells into two categories. So one is myeloid stem cell. One is myeloid stem cell and second will be your lymphoid stem cell. So we divide hematopoietic stem cell into myeloid stem cell and lymphoid stem cell. If I say this lymphoid stem cell, this myeloid stem cell, this will produce myeloblast. This will produce myeloblast. Similarly, we do have some other cells, like if I say erythroblast, megakaryoblast, So try to understand this. Myeloid stem cell will produce myeloblast. Erythroblast will form your reticulocyte. So what is the meaning of reticulocyte? Understand this. Reticulocytes are nothing. These are, you can remember, these are called baby RBC. Reticulocyte means these are your baby RBC. Similarly, if I say this megakaryoblast, they will proliferate to form megakaryocyte. And this megakaryocyte, remember, this is nothing, this is your baby platelet. So today I told you two baby RBC and baby platelet. Now these baby will eventually, they will grow. So these babies will grow. So understand this reticulocyte will produce your erythrocyte. This reticulocyte will produce your erythrocyte. This will produce your erythrocyte and this baby platelet, megakaryocyte, will produce mature platelet. So as you know, erythrocytes are also called as RBC. And platelets, these are also called as thrombocyte. So till now, just I am telling you basic, like an overview, what we should study in this chapter. So it is not important, nobody will ask you a question, but you should know the basic thing, how these cells are produced. If I say this myeloblast will produce myelocyte. Always remember, blast means immature cell, cyte means mature cell. This myelocyte will produce National Board of Examination. NBE. NBE stand for neutrophil, basophil and eosinophil. Clear? Then this lymphoid stem cell, this will produce lymphoblast. This lymphoblast will produce lymphocyte. And this lymphocyte, if I say this lymphocyte, we have two type of lymphocytes, B lymphocytes and T lymphocytes. So if you say this B lymphocyte will further divide, it will produce plasma cell. It will further produce plasma cells, and plasma cells are the one that will produce immunoglobulins. These plasma cells will produce immunoglobulins. Okay, so understand why I am teaching you this thing, because you should know what we need to study in hematology. So understand, in hematology, we need to study about this basic thing. First is hematopoietic stem cells. Hematopoietic stem cells, these are precursor cells or the stem cells or the main cells. We call them precursor cells or osteoprogenitor cells or main cells. So understand this hematopoietic stem cells, these are positive for a CD marker CD34. So first MCQ that I am asking you is hematopoietic stem cells, they are positive for which CD marker? CD34. Then understand this, baby RBCs are called, baby RBCs are your reticulocyte. Baby RBCs are reticulocyte. So remember, reticulocytes are nothing, these are your baby RBC. And if I say baby platelets are nothing, these are your megakaryocyte. These are your megakaryocyte. Now see, in hematology, what we need to study? We need to study disorders. We need to study disorders. If I say the disorders like anemia. Anemia means we are dealing with this part. RBC disorders. Right? If I say leukemia and lymphoma, in leukemia and lymphoma, we need to focus on this part. Means lymphoblast and myeloblast. If I say platelet disorders, means we need to study platelet disorder and we need to study plasma cell disorder. Plasma cell disorder, one of the plasma cell disorders is multiple myeloma. So these are 4 sections in hematology that we need to focus. See once again, anemia, RBC disorder, platelet disorder, WBC disorder also called as leukemias and lymphoma, and plasma cell disorder. Plasma cell disorder means multiple myeloma. Am I clear? So here just I want to give you a basic thing. Understand this, plasma cell tumor is called multiple myeloma. More cells means more immunoglobulin. So remember, plasma cell tumor, multiple myeloma, what we see? We see hypergammaglobulinemia, increased number of immunoglobulin. So this is what we need to study. So based on this, you should know how to read a CBC. So what we see in CBC, understand. In CBC, what we see, first thing, in CBC we see hemoglobin. Clear? In CBC we see hemoglobin. So if I say less than 13 in males, less than 13 in males and less than 12 in females, less than 12 in female, this is what we call anemia. This is what we call anemia. So anemia is defined as decrease in hemoglobin if I say it is less than 13 in males and less than 12 in females. Now just understand this, WHO was doing a survey. What they noticed, most of the Indian females, they are having hemoglobin like in range of 70, like in range of 10, 9.5, 11. And they noticed these Indian females, they don't have much symptom. So for Indian females, they have reduced the range. So understand this, for Indian female, the range is less than 11. So understand this, anemia, how we defined? We defined anemia when hemoglobin values are less than 13 in case of males, less than 12 in female and less than 11 in case of Indian female. Am I clear? So anemia we defined by this thing. If I say sometime they will not give you, so this is about hemoglobin. So hemoglobin, if I say hemoglobin, what is the normal value? If I said the normal value of hemoglobin that you should remember for your exam. So normal value of hemoglobin, this will be, if I say normal hemoglobin, this will be in the range of 12 to 16.5. But for Indian, they have reduced the range. Am I clear? So understand this, less than 13, what I told, this is less than 13, what I told, this is for males, less than 12, this is for females, and less than 11, this is for Indian females. Any doubt, guys? So if I say anemia, we can define as decrease in hemoglobin or hematocrit. Decrease in hemoglobin or hematocrit is called anemia. Decrease in hemoglobin or hematocrit is called anemia. So just I want to show you a CBC report, and based on this report you can see here it is written hematocrit, right? So either you can see hemoglobin or you can see hematocrit. So how we calculate hematocrit? Understand how we calculate hematocrit? Hemoglobin, multiply this hemoglobin by 3. This will be your hematocrit. Hematocrit is, in short, we write HCT. So understand this, hematocrit, how we calculate? Multiply hemoglobin by 3. So if I give you example, a person is having hemoglobin, I'll give you my example. My hemoglobin, let me say it is 15. So 15 into 3, my hematocrit will be 45. Clear? My hematocrit will be 45. Okay, some more parameters you will see. Reticulocyte. I told you before, what is reticulocyte? Reticulocyte, these are nothing, these are your baby RBC. These are your baby RBC. These are your baby RBC. So normal reticulocyte count is 0.5 to 1.5%. Normal reticulocyte count is 0.5 to 1.5%. If reticulocyte count is decreased, we call this hypoproliferative anemia. If it is increased, we call this hyperproliferative anemia. Understand this concept. Okay, if I say we have anemia due to decreased production and anemia due to increased destruction. So understand this. Normocytic anemia we can divide into two categories. Anemia that occur due to decreased production of RBC and anemia that's occurring due to increased destruction. Now understand, RBC destruction is more. RBC destruction is more. This anemia is also called as hemolysis. Destruction of RBC is called as lysis, hemolysis. So this type of anemia is called as hemolytic anemia. We call this hemolytic anemia. This is called as hemolytic anemia. So try to understand this very carefully. Listen to me very carefully now. Production is decreased. Production is decreased. Production is decreased means baby RBCs are also not formed. Means baby RBC means reticulocyte count. So baby is decreased. So since baby is decreased, remember, adult RBCs or adult mature form, they are also decreased. Simple. Decreased production means production किसका नहीं हुआ है? बच्चों का ही नहीं हुआ है. Baby RBCs are not formed. So baby RBCs are less. So mature RBCs are also less. But understand this here, reticulocyte count, let me put a blank here. RBCs as soon as they are maturing, they are dying. RBCs, they are dying means RBC number is less. RBC number is less because they are dying early. When they are dying early, this will give a signal to bone marrow. So bone marrow will produce more. Bone marrow will try to produce more RBC. So bone marrow will produce more reticulocyte count. So reticulocyte count will be more, but again as they mature, they will die. See once again. In anemia due to decreased production, reticulocyte count is decreased. But if I say anemia due to increased destruction, what you will notice, RBCs as they mature, they are dying. But this will give a signal. So this will give a signal to bone marrow and bone marrow will try to produce more RBC. So reticulocyte count means baby form will be more. Am I clear? So understand this, whenever you suspect hemolytic anemia, your next investigation will be reticulocyte count. So basically here I want to add one line, that is reticulocyte count. This will increase. In which anemia? In hemolytic anemia. Is it clear, guys? Am I clear to everyone? So reticulocyte count means they are increased in all hemolytic anemia because that is giving a signal to bone marrow. Now next thing what I want you to, after, suppose you have seen a report, there's a patient who is having hemoglobin value 10, or I can say 9.5. You understood it is anemia. Clear? You understood it is anemia. So either you are saying, suppose you are seeing a CBC report like this, you are seeing a CBC report, hemoglobin values 9. You are seeing hematocrit values 27.5, let me say 27, right? So you understood it's anemia. But there are a lot of types, there are huge type of anemia. Understand this, in hematology, you should not be fast. You should narrow your diagnosis, go step by step. The next thing what you will look at is, once you know it is anemia, the next thing you will look at MCV. MCV is mean cell volume or mean corpuscular volume. So understand this, next thing you will look at is mean corpuscular volume. So MCV, if I say normal value is 80 to 100 femtoliter. FL is femtoliter. 80 to 100. So remember MCV. So wherever guys I'll write the Q, this means these are your exam questions. So if I say MCV value is 80 to 100 femtoliter. If I say MCV is corresponding to size of RBC. So MCV correspond to size of RBC. So RBCs, are they big or are they small? So that we should know. So based on MCV, if I say based on MCV, we divide anemia into 3 categories. Just listen to me very carefully. And if you know this classification, trust me, you will be able to solve one question of your exam. So if I say based on MCV, what I can say, this can be less than 80. It can be 80 to 100, or it can be more than 100. Am I clear, guys? So just let me know, give your input. If I say MCV value is less than 80, this anemia is called microcytic anemia. This anemia is called microcytic anemia. If I say MCV value is normal, what is normal value? 80 to 100. So this anemia is called as normocytic anemia. And if I say MCV value is more, what we will call this? Tell me anyone. What we will call this? Less than 80 means microcytic. If I say normal means normocytic, this is what we call this macrocytic. Clear? So we divide anemia into 3 categories: microcytic, normocytic, macrocytic. If RBCs are having smaller size, so remember they will have less color. So we also call this hypochromic. So remember we call this hypochromic. Normal RBCs will have normochromic. So we call this normal color means normochromic. So we divide anemia, remember, into 3 categories, that is microcytic hypochromic, normocytic normochromic, and macrocytic anemia. So first thing you should remember this. Anemia we divide into 3 categories: microcytic hypochromic, normocytic normochromic, and macrocytic. Now once you know this, so understand this, if I say microcytic hypochromic anemia, so remember these anemias, there are 5 anemias which include in this category. This you can remember by a mnemonic Sheetal. So if I say what is this Sheetal, S stand for Sideroblastic Anemia. If I say I stand for Iron Deficiency Anemia. T is your thalassemia. A is your anemia of chronic disease, AOCD. Anemia of chronic disease, and this is your lead poisoning. So understand this microcytic hypochromic anemia we can divide. It is actually macrocytic normochromic. Even size is bigger, it will not impart more color. Color will be normal. So we just call this macrocytic. So we divide this into Sheetal, Sideroblastic, Iron Deficiency Anemia, Thalassemia, AOCD is anemia of chronic disease, and L is lead poisoning. So what I want you to understand is, whenever you see a report of MCV, suppose, understand guys, listen to me very carefully. If I ask you, suppose you are seeing a patient, hemoglobin value is 9. MCV is 65. 65 means less than 80. Then understand this, then anemia can be from this list. That's it. Am I clear or not? Just try to understand this. If you see MCV value of 65, 70, 75 means less than 80. If you see MCV value less than 80, it means It should be from these 5. Which 5? Sheetal, Sideroblastic, iron deficiency, thalassemia, anemia of chronic disease, and lead poisoning. Am I clear? Okay, Karthik, a question for you. Karthik, try to answer. Karthik, if I ask you, a patient is having MCV value 102, the answer is no. Why? Because you know, if it is microcytic hypochromic, it should be from this list. Am I clear? Okay, understand. So what you have to remember in macrocytic? What you have to remember in macrocytic? So understand this, macrocytic can be due to B12 deficiency. Macrocytic can be due to B12 deficiency. B12 is your vitamin B12, cyanocobalamin. It can be due to B9 or folate deficiency. It can be due to B9 or folate deficiency. Macrocytic, remember, macrocytic anemia sometimes you can see in alcoholics. So it can be due to alcoholism. शराब पीने से होता है. Macrocytic anemia sometimes you can see due to thyroid diseases and liver disease. So understand, these are the cause of macrocytic anemia. For your exam, you have to remember 2 important one, that is B12 and B9. So these 2 are important. These 2 are important. So this is about your macrocytic anemia. Am I clear? So I told you till now, microcytic sheetal, normocytic, normochromic will come, we'll discuss those later, and macrocytic means B12, B9, liver disease and thyroid diseases. That's you have to remember. Clear? Now see, if I say normocytic, normochromic anemia, so just I am writing here normocytic, normochromic anemia. So what is the meaning of normocytic, normochromic anemia? If I say MCV value is in the range of 80 to 100, clear guys? MCV value is in the range of 80 to 100. So if I say this normocytic, normochromic anemia, it can occur because of 2 reasons. It can occur because of 2 reasons. If I say reason number 1, it can occur when RBC count is decreased. RBC count is decreased, that is what we call this decreased production. The same thing I told you. It can occur because of decreased production, means RBCs are not producing, or it can occur because of increased destruction. Now you will be telling me the answer, guys. Tell me, if I say anemia due to decreased production. Anemia due to decreased production means what will not produce? What about reticulocyte count? Just give your input. Reticulocyte count will be normal, increase or decrease. And what will be reticulocyte count here? Tell me the answer. If I ask you anemia due to decreased production means nothing is producing. Baby RBCs are also not producing. So reticulocyte count will decrease. Yes, this will decrease. And if I say increased destruction, this is what we call this hemolytic anemia. Hemolytic anemia. So what about reticulocyte count? In hemolytic anemia, reticulocyte count will increase. Am I clear? Is it clear? Now just try to understand this. If I say decreased production, means there is decreased production of RBCs. So when you can see decreased production, understand this. If I give you example of anemia, if I say for erythropoiesis means synthesis of RBCs. For synthesis of RBCs or for erythropoiesis, you need a signal. That signal is coming from kidney. Kidney is producing a hormone called erythropoietin. Am I clear? Listen to me very carefully. Kidney produce a hormone called erythropoietin. But if patient is having CKD means end stage renal disease. In CKD, what you will see, kidneys are damaged, so kidneys will not produce erythropoietin. Kidneys are no longer producing erythropoietin. And remember, I told you this hormone is needed for erythropoiesis. Am I clear? So first cause of decreased production is CKD. So in CKD, what is the problem? Decreased production of, CKD means chronic kidney disease. So in CKD, there is decreased erythropoietin, means decreased erythropoiesis. Second, if I say, I gave you like there is hematopoietic stem cells. Suppose they are totally lost. There is complete destruction of hematopoietic stem cells, that is seen in aplastic anemia. So next cause will be aplastic anemia. So aplastic anemia means what you will see here, you will see pancytopenia. All RBC, WBC, platelets, all are lesses, all are decreased. So pancytopenia is a feature of aplastic anemia. RBC, WBC, platelet, all are decreased. There is a virus, this virus is called parvovirus B19. So we have a virus, the name of this virus is parvovirus B19. So understand this virus carefully. This virus can cause huge damage to your hematopoietic cells. Either they can damage your erythroblast, means RBC producing cells are totally lost. So means WBC platelets are normal, only RBC producing cells are lost. We call this pure red cell aplasia. Pure red cell aplasia means RBC producing cells are totally lost. And if I say this parvovirus B19, this parvovirus B19, sometime it can lead to, suppose a patient is already having anemia, like a patient is having sickle cell anemia. In those patients, it can lead to worsening of symptom. We call this aplastic crisis in sickle cell anemia. Means patient is already having sickle cell anemia and now he developed aplastic anemia. That is what we call aplastic crisis. So if I ask you a microbiology, pathology, medicine overlap question, which virus is having predilection to damage your hematopoietic cells? Answer is parvovirus B19. Clear? So which virus can damage? Guys, wherever I am writing Q, these are FMG exam questions. So you should also write this Q in your notes. So which virus? Answer is parvovirus B19. Clear? So which virus can cause? It is parvovirus B19. Am I clear? Parvovirus B19. So CKD, aplastic anemia, parvovirus B19. Is it clear? These are causes of decreased production. Decreased production, right? If I say there can be decreased production of RBCs whenever there is some leukemias involving your bone marrow. So hematopoietic stem cells are gone. That is, this decreased production can also occur due to some leukemias, that is cancer. So understand this, I told you there are 4 causes of decreased production: CKD, aplastic anemia, parvovirus B19, leukemias. Am I clear? So you don't have to remember leukemia, you have to remember these 3. 3 main means CKD, aplastic anemia, parvovirus B19. Gitika, Harsimrit, Pancholi, Dharmesh, any doubt to anyone? If I say anemia due to increased destruction, anemia due to increased destruction, I told you this anemia is called as hemolytic anemia. Any doubt, guys? What we call hemolytic anemia? If I say this hemolytic anemia, means RBCs are dying. Means RBCs are dying. So understand this, RBC can die where? RBCs can die at 2 places, right? So if I say first place where RBCs are dying, they are dying in some extravascular space, right? We call this extravascular hemolysis. Extravascular hemolysis. So mainly they are dying outside the vessels. So I am adding a word predominantly. So we call this predominantly extravascular hemolysis, or here I can say if RBCs, they are dying in the vessel itself. We call this predominantly intravascular hemolysis. So RBCs, they can die outside the vessels, they can die inside the vessels. They can die outside the vessel, they can die inside the vessel. Clear? So understand this very important topic, again a conceptual thing. If I say this is RBC, these RBCs are where? These are in the blood vessel. So if I say this is your blood vessel, inside blood vessel, if I say this dumbbell shape, these are your RBCs, right? And these RBCs, they are having a pigment. That pigment is called as hemoglobin. Clear? Simple. So RBCs, where they are dying? They are dying inside the vessel. So when RBCs are dying, understand this pigment will come out. This pigment will come out. Hemoglobin will come in the blood vessel, right? Hemoglobin will come in the blood. RBCs are dying. What we call this? We call this hemoglobinemia. Hemoglobinemia. So understand this, hemoglobinemia means more hemoglobin in the blood vessel, in the blood. When there is more hemoglobin in the blood, there will be more hemoglobin in the urine. They will go out through the kidney. There will be hemoglobinuria. Hemoglobinuria. Clear? So understand this, intravascular hemolysis means RBCs, they are dying in the vessel itself. So what you will see hemoglobinemia, you will see hemoglobinuria. So when these RBCs are dying, understand this, RBCs are dying, there is a protein that take care of this dead RBC. This protein is called haptoglobin. Haptoglobin. So understand this, suppose if too much RBCs are dying, means too much hemoglobin is coming out. So this haptoglobin levels are not sufficient. Haptoglobin will take care of this dead hemoglobin or dead RBCs. Who will take care? Haptoglobin. So let me say this, one haptoglobin we have for hemoglobin. But now understand this, now a lot of hemoglobin. But now what you notice, a lot of hemoglobin, they are dying. Clear? If you see a lot of hemoglobin, they are dying, then haptoglobin is not sufficient. So I can say haptoglobin levels are not enough. When haptoglobin levels are not enough, we call this as decreased haptoglobin. So haptoglobin levels are not sufficient. Now see, normally in your body, hemoglobin, RBCs are dying. RBCs, they complete their lifespan after 120 days. Right? So these are called senescent RBCs. These are dead RBCs. They will die after 120 days. Who will take care of them? They are being taken care by haptoglobin. But now there are more RBCs. More people are dying. There is no place in graveyard. There are the person who is taking them to graveyard. That is haptoglobin. So haptoglobin is not sufficient. Is it clear? Now understand this. When RBCs are dying, RBC, they have an enzyme. From the RBC, one enzyme will come out. This enzyme is called LDH. From biochemistry, in biochemistry you will see RBCs, they have an enzyme called LDH. So when RBCs are dying, more LDH will come out. More LDH will come out means LDH level will increase. Clear? LDH level will increase. Guys, getting me or not? Any doubt to anyone? Now see, if I say this is the structure of your tubules, when RBCs are going or they are excreting, some of the RBCs they get stuck in the tubules. There is hemoglobinuria. Hemoglobinuria means hemoglobin is released. So some of the hemoglobin, it gets stuck. ये वहाँ फंस जाएगा in the tubules. And one day you thought of drinking beer. So what happened with the beer? You will have more urine. More urine means there is more urine flow. So sometime you will see after few days this precipitated form. After 2 to 3 months, this hemoglobin will precipitate Precipitated form of hemoglobin is called hemosiderin. Precipitated form of hemoglobin is called as hemosiderin. So after 2 to 3 months, you will see this will break down and this will be released, and this will be released in the urine. Clear? So understand this. The last feature that you will see in our patient will be hemosideриnuria. Hemosideриnuria. Sideриnuria. So remember, in intravascular hemolytic anemia, you will see 5 features. What are these 5 features? You will see hemoglobinemia, hemoglobinuria, low haptoglobin, increased LDH, and hemosideриnuria. But remember, suppose if you are having hemolysis today, in your body, hemosideриnuria will occur after 2 to 3 months. This will occur after 2 months or after 2 to 3 months. So if I ask you, tell me the answer. What are the 5 features of intravascular hemolysis? Hemoglobinemia, hemoglobinuria, low haptoglobin, increased LDH, and after few months you may notice hemosideриnuria. Hemosideриnuria. Am I clear? If I say RBCs, they are dying outside the vessel. Outside the vessel means where? Outside the vessels means they are dying in a reticuloendothelial system. Reticuloendothelial system means your spleen, lymph node, right? They are dying in reticuloendothelial system means spleen, lymph node. They are dying into spleen, they are dying into lymph node. If I say RBCs, they are dying in the spleen. So sometime you will see patient with anemia can develop splenomegaly because more RBCs are going to spleen, so splenomegaly, spleen will enlarge. If you see some of the RBCs, they are going into lymph nodes, so sometime you will see in anemia, you can also see lymphadenopathy. You will see lymphadenopathy. RBCs are dying where? They are dying into lymph nodes, they are going into lymph nodes. Now see how RBCs are dying, understand how RBCs are dying. This is hemoglobin. If I say hemoglobin, hemoglobin is made up of heme, right? This is heme plus globin. Hemoglobin, heme plus globin. If I say in biochemistry study end product or final product of hemoglobin degradation, final product of hemoglobin degradation will be bilirubin. Ultimately, hemoglobin is broken down to produce bilirubin, right? So more hemolysis means more hemoglobins are breaking down, so they can produce more bilirubin. So third feature you will notice, patient can develop increase in bilirubin. Increase in bilirubin. So sometime you will notice patient can have more bilirubin. There will be increase in bilirubin. Clear? More bilirubin. If you say more bilirubin means this bilirubin, more bilirubin can cause jaundice. Patient can develop jaundice. So sometime remember, anemia patient can also develop jaundice. More bilirubin means patient can develop jaundice. If you see jaundice patient is developing, sometimes this bilirubin can form stone in your gallbladder. This is what we call this gallstone. Patient can develop gallstone. So remember, in gallbladder we have 2 type of stone. Most common stone are cholesterol stone. But this is bilirubin is a pigment. This is what we call this pigmented gallstone. Pigmented gallstone. So remember, gallstone we have 2 type. Cholesterol, that is more common, that is seen in obese person. This is called pigmented gallstone. So understand guys, I told you 5 features of extravascular hemolysis and 5 features of intravascular hemolysis. So see, if it is extravascular hemolysis, what you will see? You will see splenomegaly, lymphadenopathy, you will see hyperbilirubinemia, you will see jaundice and gallstone. In intravascular hemolysis, what you will see? you will see hemoglobinemia, hemoglobinuria, low haptoglobin, increased LDH, and after a few months you may notice hemosideruria. Am I clear? Now understand, you should know what are the diseases, what are the example of diseases where you will see predominantly extravascular hemolysis, and what are the example of diseases where you will see predominantly intravascular hemolysis. So let's see them one by one. What are the example of disease where you will see predominantly extravascular hemolysis? So extravascular hemolysis you can see in hereditary spherocytosis. Hereditary spherocytosis. We call this HS. Extravascular hemolysis. Extravascular hemolysis you can see in one more condition called hereditary elliptocytosis. Hereditary elliptocytosis. You can see this extravascular hemolysis in hemoglobin. I am writing in short, hemoglobin C disease. Hemoglobin C disease. And if I say the fourth cause will be your sickle cell anemia. So mnemonic, remember, we can remember this by mnemonic triple HS. Triple HS, hereditary spherocytosis, hereditary elliptocytosis, hemoglobin C disease, and sickle cell anemia. So these are the causes of predominantly extravascular hemolysis. If I say intravascular hemolysis, if I say example of diseases with intravascular hemolysis, where you will see intravascular hemolysis in autoimmune hemolytic anemia, microangiopathic hemolytic anemia, MAHA, paroxysmal nocturnal hemoglobinuria, G6PD, glucose 6 phosphate dehydrogenase deficiency anemia. And you will see this where? In parasite infection. You will see this in certain parasite infection. So I'll come to this full form. Understand this: AIHA, MAHA, PNH, G6PD deficiency anemia, parasite infection. These are the causes of intravascular hemolysis. Now see, this is like given in RSN in a detailed view. So I just try to summarize this. Look at the screen very carefully and try to understand what I want to explain here. If I ask you what feature you will see in AIHA, what features you will see in MAHA, what you will see in PNH, what you will see in G6PD deficiency anemia, the answer is same. You will see hemoglobinemia, hemoglobinuria, low haptoglobin, increased LDH, and after a few months hemosideruria. Similarly, if I ask you what features you will see in hereditary spherocytosis, so you can see splenomegaly, lymphadenopathy, hyperbilirubinemia, jaundice, and gallstone. So these are common features. These are common features. So today I'll teach you, like now exam pattern is totally changed. They are asking you approach. They are asking you question like a patient, a doctor-patient question, like a real patient example they are giving. So see, these are common features. So all these anemia will have this type of features, and all these anemia will have these features. Am I clear? Now I want you to remember this classification the same way that I am remembering. Am I clear? So let us write this classification once again, because there is one question that they ask in exam. So see, I'll tell you the example sample question. Sometimes they ask this type of question, like if I ask you, a 30-year-old female is having pain, pallor, jaundice, icterus. She is otherwise healthy but sometimes develop intermittent claudication. A CBC report is telling you hemoglobin value of 8.5. Hemoglobin value of 8.5 and MCV value of 65. What is the diagnosis? So understand this. Try to answer. MCV 8.5, MCV 65, and hemoglobin is 8.5. Tell me the answer. Tell me the answer. It is microcytic hypochromic anemia. You should remember Sheetal. So these three cannot be the answer. Why? Because in these three, In these three, MCV will be in the range of 80 to 100. Am I clear? 80 to 100. So I'm just trying to, because like always I tell you that hematology is pure conceptual thing. So if I say one more, a 5-year-old boy is having hemoglobin value of 7.5, MCV in the range of 89. MCV in the range of 89. If you notice, the patient is developing features like pallor, icterus, hyperbilirubinemia, jaundice. So what is the answer? Yes, in these three you will see predominantly intravascular. This is only extravascular. Am I clear? So answer is clear. So now I want you to remember the classification. So I am drawing the classification once again. See what I told you. I told you we can divide anemia based on MCV, right? So same thing I am drawing again. MCV I told you normal value 80 to 100. MCV I can say it is less than 80. MCV can be more than 100. Right? If I say less than 80 means microcytic hypochromic. This time I am just drawing in a fast forward way. Microcytic hypochromic, and if I told you microcytic hypochromic, we have Sheetal. Clear? Same thing I told. If I say MCV 80 to 100, this anemia is normocytic normochromic. In normocytic normochromic, what I told you, it can be due to decreased production, it can be due to increased destruction. We'll come to this. Okay, macrocytic, this is our macrocytic anemia. And macrocytic, what I told you have to remember two things. You have to remember B12 and B9. Now understand this. Normocytic normochromic anemia, I told you decreased production. Remember, it can be due to CKD or it can be aplastic anemia. Remember these two, that's it. CKD or aplastic anemia. Increased destruction means RBCs are dying. So where they can die? Extravascular, intravascular. Intravascular. If I say extravascular, what I told you, triple HS, right? Intravascular, remember full form, simple. How I remember? Those who are having bigger name. Full form means AIHA, autoimmune hemolytic anemia. Full form G6PD deficiency anemia, glucose 6 phosphate dehydrogenase deficiency anemia. Again full form paroxysmal nocturnal hemoglobinuria. Full form microangiopathic hemolytic anemia. Again full form. And parasite. Clear? So now is it easy to remember? Is it easy, guys? So understand this, full form plus parasite, these are predominantly your full form and parasite. Any doubt to anyone? So one by one, this classification is very, very important, because sometimes they ask you a question. They'll give you a big clinical case, a big question, but in the end they will mention MCV value. In the end they will mention MCV value is 65. It means it is Sheetal. In the end they mention MCV value is less, means it is microcytic hypochromic anemia. In the end, sometime if they mention MCV value is more than 100, then you automatically understand it is B12 or B9. It is B12 or B9. Am I clear? So one by one we'll discuss these different type of anemia. So this is your basic classification. So after classification, I am telling you some more things about this anemia, what we should remember. So understand this one by one. I told you MCV, so classification is ready. After MCV, what is important? MCH. So just remember the values of MCH. So remember, normal value is 27 to 32 picogram. So next thing is your MCH. MCH is your mean corpuscular hemoglobin. It is your mean corpuscular hemoglobin. If I say normal value is 27 to 32. If I say what this MCH represent, it will represent average hemoglobin in your single RBC. And how we calculate this? We calculate this by hemoglobin divided by RBC count. We calculate this by hemoglobin divided by RBC count. Okay, if I say next is your MCHC. MCHC is nothing, it is hemoglobin in a given volume of packed RBC. If I say how we calculate, you can calculate this simple by MCV divided by MCH. That is what we call this mean corpuscular hemoglobin concentration. And normal value is 33 to 37. It is 33 to 37. So these are some values that you should remember, like they have some significance, that is important. Okay, next parameter is RDW, red cell distribution width. So this is important. Red cell distribution width. Red cell means RBC distribution width. So understand this, how we calculate RBC distribution width. This RDW is corresponding to different size RBCs. Suppose we have a patient who is having abnormal shaped RBC, abnormal size RBC. So that is called anisocytosis and poikilocytosis. Anisopoikilocytosis means if you are having abnormal shape and size of RBC. Means some RBCs are smaller, some are bigger, some are having different shape. So if you see anisopoikilocytosis, remember this is suggestive. This RDW will increase. So whenever you see anisopoikilocytosis, then remember RDW will increase. So in any CBC report, if you see RDW values are 17, 20, means more than 14.5. It means you should understand this patient is having different shape of RBCs, shape and size RBCs. Clear? So understand this. If I say this RDW is increased where? It is classically increased in iron deficiency anemia. It is increased where? In iron deficiency anemia. RDW is increased where? In iron deficiency anemia. This is you have to remember. So RDW correspond to abnormal shape and size of RBC. Am I clear, guys? So with this in background, we will discuss the different types of anemia. So I hope the things are clear. This is a basic introduction. By just seeing CBC report, you can get an idea what is the question and what is your patients. So they are asking you patient type question these days. So one by one, with this in background, we can discuss different type of anemia. So I have told you the classification already. That is, we can divide into microcytic, normocytic, macrocytic. Am I clear? Now see, if I say any patient who is having anemia, any type of anemia, be it megaloblastic, be it macrocytic, normocytic, any type of anemia, it will have some common sign and symptom. We call them general sign and symptom. So what are this general sign and symptom? Understand this. Whenever you are having anemia, patient will develop pallor. There will be pallor. There will be skin pallor. If I say along with pallor, you will notice patient can have pain. There can be pain. Sometimes patient can have pain with intermittent pain. Intermittent pain, what we call this? We call this claudication. Means patient will complain like suddenly I am having spasm or spastic pain in my legs, right? That is, patient can develop giddiness. So this can be a female, she will tell you chakkar aate hain, ulti jaisa man hota hai. There can be nausea. Because of anemia, understand this, because of anemia, there is hyperdynamic circulation. Your heart is trying to beat faster. So patient can develop palpitation. There can be palpitation, right? There can be palpitation. Palpitation means you will feel your own heartbeat. Palpitation is nothing, it is a feeling of your own heartbeat. There can be increase in heart rate. That is tachycardia. There can be palpitation, there can be tachycardia. Sometimes patient can develop a severe generalized weakness, like it will be extreme fatigue, or feeling low, feeling tired, and some of these patients can develop a angina-like chest pain. So it's not MI, but it's like angina-like pain. Angina-like pain. So these are common symptoms which any patient will develop. And last, if I say, patient can develop shortness of breath. So see, these are common symptoms that you can see in any anemia. So it's a common complaint of Indian females. Why? Because I told you Indian females are mostly anemic. A common complaint that Indian female will have is she will say, मुझे चक्कर आते हैं, I am feeling dizzy, giddy, चक्कर आते हैं, कमजोरी लगती है, weakness. That is a common complaint. So these are general signs and symptoms of any anemia. A pallor, pain, claudication, giddiness, nausea, palpitation. These are general signs and symptoms. If you add something more in this, then that will become specific. So see, by looking at these symptoms, you cannot say which type of anemia. Clear? Am I clear? So pallor, pain, claudication, nausea can be in B12 deficiency. It can also be in iron deficiency. For that, you need to listen to me the whole day. How we can approach a patient, that is important. Am I clear? So these are non-specific symptom or general symptom of any anemia. Clear? General symptom of any anemia. Okay, so one by one we'll discuss each of this type of anemia. First and the most important is your iron deficiency anemia. Iron deficiency anemia. So if I say most common type of anemia, what will be your answer? Most common type of anemia. This will be your iron deficiency anemia. I am writing in short IDA. So most common type of anemia is iron deficiency anemia. Okay, if I ask you another question, most common type of anemia in pregnancy. Guys, what will be your answer? Most common type of anemia in pregnancy. Tell me your answer. Dharmesh, which is more common in pregnancy? The answer for this question is dimorphic anemia. Dimorphic means both iron and folate. Both iron and folate. So in pregnancy, understand this, we give folate supplement to mother. So understand this, dimorphic means both iron and folate. But if I ask you, suppose if I am a cunning examiner, मैंने आपको दोनों option दे दिए, iron and folate. So remember, iron deficiency is still commoner than folate. So remember, most common type of anemia overall, iron deficiency. Most common type of anemia in pregnancy, it's also iron deficiency. But agar option mein sometimes they give the word dimorphic. Dimorphic means both iron and folate. And that is a better answer. That's a more correct answer. Clear? So remember, most common type of anemia is iron deficiency anemia. So one by one, we should know the basic pathophysiology of iron deficiency. So let's try to understand this one by one, how iron is absorbed. So if I say we have iron, so try to be with me and try to understand. This iron is having two sources. Two source means in your body, how you can get iron. So source number one is diet. So you are taking jaggery, spinach, green leafy vegetables. So that is giving you iron. That is from your diet you are getting iron. Second source of iron is some RBCs, they have complete their lifespan, like 120 days. Some RBCs, they have lived their whole life, then they are dying. When they are dying, they will release iron. Am I clear? Getting me or not? These RBCs are called senescent or destroyed RBCs. Senescent or destroyed RBCs. So understand, this body can have two sources of iron. What are these two sources? One is your diet, second is your destroyed or senescent RBCs. Right? So understand this, if I say this senescent or destroyed RBCs, they are going into your stomach or your GI tract. So understand this, if I draw an image here, these RBCs or this iron is going into your stomach. This iron which is going into your stomach, this iron is in which form? It is in ferric form. Ferric form is called Fe3+. ferric form is called Fe3 plus. Then this Fe3 plus will convert into ferrous form. Ferrous form is Fe2 plus. Am I clear? In your stomach, this ferric form is converted into ferrous form. Now see, if I say this ferrous form is converted into ferric form is converted into ferrous form, this conversion need an enzyme, that is your hydrochloric acid. It's basically your acid, HCl. So if I say this is your ferric form and this will be your ferrous form. So if I ask you which form is entering into duodenum, which form is entering into duodenum, tell me the answer, ferrous or ferric? Which form is entering into duodenum? Tell me the answer, guys. Which form is entering into duodenum? Ferrous or ferric? Nowadays they are asking detailed questions, so we should know the basic thing. If I say Fe2 into Fe2 into, remember into means 2. So Fe2 into, so ferrous form is going into your duodenum. Clear? So ferrous form is going where? Into duodenum. In the duodenum we have enterocyte. So Fe2, remember Fe2 into enterocyte. Enterocyte means these are the cells. So this ferrous form is going into your enterocytes or into your duodenum. In the duodenum what we have? We have Fe2 plus form. Now understand this Fe2 plus or this Fe2 plus, now it is entering your duodenum, your enterocyte. So if I make a drawing once again, this is your enterocyte, these are your enterocyte. Now see, it is enterocyte, what you notice? This is your enterocyte. In this enterocyte, which form is entering? I told you, your Fe2 plus. So Fe2 plus is entering your enterocyte. So these are your enterocytes. So Fe2 plus is entering your enterocyte. From enterocyte it is going to your blood. And in blood it will bind with a protein called transferrin. So it is, understand this, in the blood it is going, this form is going into your blood vessel. Then it will go to blood vessel. In blood vessel this iron will be binding with which protein? That is called transferrin. So just I want to add you tell you something, a few things, understand this, a few questions, that iron absorption occur in duodenum. Transport form of iron in the blood vessel is transferrin. Clear? Transport form of iron in the blood vessel is called transferrin. Am I clear? Transport form of iron is called as transferrin. So if I say, now understand this, if I want to draw one more drawing here, so try to understand this. With this drawing you can answer every question. So see once again this drawing. If I say we have, let me make a drawing once again to make you realize, this is your Fe2 plus. This Fe2 plus is entering. When it's entering, it can enter by 2 channel. So these are the 2 channel. If I say this first channel is called DMT1. This question came in AIMS exam. It is your divalent metallic transporter 1, DMT1, or it can go by heme carrier protein. Heme carrier protein. So understand this. This Fe2 plus is entering your duodenum by 2 transporter DMT1 or heme carrier protein. So once this Fe2 plus is here, you can notice this Fe2 plus is here, right? Now this Fe2 plus from your intestine, either it can go to stool. So either it can go to stool, if it is in more amount, it can go to stool and it will give you some color to stool. So sometimes some patient they complain of melena means black tarry stool, means iron is going, or usually this Fe2 plus Fe2 plus with the help of ferroportin. With the help of ferroportin. This is your ferroportin. Right? This Fe2 plus will come out. So if I say with the help of ferroportin, this Fe2 plus will come out. Right? Now understand this, Fe2 plus will come out. So this is the same detailed thing which I am telling you now. Previously I told you in short, now I am telling you in detail. This Fe2 plus now will convert again into ferric form. Fe3 plus. This ferric form will bind with transferrin. Fe3 plus is binding with transferrin. Transferrin means this is occurring where? In the blood vessel. In the blood vessel. Now understand this, from this blood, it can go to bone marrow. This iron can be going into bone marrow. Right? In bone marrow to either for storage or to synthesize some new cells, or this is going to liver. Or is going to liver. Clear? So understand this once again. Let's see this once again. Iron is going, you are taking iron in the form of diet. It's going into your stomach. From stomach it is converting into ferric form to ferrous form. Stomach is converting into ferrous form. Then it is entering enterocyte. Once it entered enterocyte, from enterocyte it will go to blood. So what's happening in the enterocytes? In the enterocyte, if I say it's entering by two transporter, divalent metallic transporter, Ames exam question. Divalent metallic transporter and heme carrier protein, then this form is going, or it is going to blood vessel with the help of a protein called ferroportin. Ferroportin, now understand, this ferroportin will convert ferrous form back to ferric form. It will merge with transferrin. Then with transferrin this can go to bone marrow or it can go to liver. In liver we have a protein that will regulate this process. This protein is called hepcidin. So the significance of this protein I will tell you later on. Because when we will discuss anemia of chronic disease, then this hepcidin becomes extremely important. Okay, so if you can remember this, that's fine. So based on this, I will tell you some question. If I say site of ion absorption. Ion absorption occur where? Tell me the MCQ and the answer. If I ask you where you will see ion absorption, try to answer, guys. Where you will see ion absorption occur where? Ion absorption site, the answer will be duodenum. Ion absorption occur in duodenum. If I say simultaneously, sometimes they ask physiology question, folic acid absorption primarily occur where? So remember, folic acid absorption primarily occur where? In jejunum. If I say B12 absorption, what will be your answer? It is ileum. So remember, these are some physiology questions that they ask in exam. Ion absorption, duodenum, folic acid, jejunum, B12, ileum. Clear? If I say this iron is stored in the liver or bone marrow, the reflection of store, this get stored. So I can say it is stored in liver or bone marrow. The stored form, if I say the reflection of stored form, is your ferritin. So if I ask you, iron is stored form of iron. Stored form of iron. So understand this, iron is stored in which form? It is stored in ferritin, as ferritin. So stored form of iron is ferritin. If I ask you a next question, transporting form of iron in blood vessel, try to answer, guys. Transporting form of iron in blood vessel. So transporting form is transferrin. And if I say one more MCQ, stored form is ferritin, transporting form is, if I say transporter for iron into enterocyte, the name of transporter, so I told you it is DMT1. divalent metallic transporter. Transporter of iron into enterocyte is DMT1. Right? And last MCQ, if I ask you, try to answer. What is the regulator of iron metabolism? Who is regulating? I told you there is a protein where in the liver, that protein is hepcidin. So these are all MCQs which you should know from. These are basically physiology. So if you are studying medicine, you should know physiology and pathology. That is more important. Is it clear? So let us see once again for the last time. Then you can, I think this will be in your fingertips. The iron is, you are taking iron from that. We have two sources, either from the diet, or you can take iron from senescent RBCs. I mean RBCs which are dying. RBCs which are dying. So if I say these destroyed RBCs are called dead RBCs. Iron you are taking, it's coming into a stomach. In which form? Ferric form. Ferric form, then it will convert into ferrous form. So Fe2 into where? Into your duodenum. In the duodenum you will see we have two transporter, DMT1 and heme carrier protein. Heme carrier protein from duodenum, it is going out. It is reaching blood vessel with the help of ferroportin. In the blood vessel it is combining with transferrin, and ultimately it is stored in the form of ferritin. We have a key regulator. That key regulator is hepcidin. So if you notice carefully, this iron is always with someone, right? It is like a dependent girl who is dependent on some person, right? So this is a dependent, means iron is always dependent on someone. We never leave iron alone. Never try to leave iron alone. Why? The reason is, if you leave this iron alone, it may generate free radical. So understand this. If I say iron should not be left alone. So it's a cunning person. You should not leave iron alone, because it can generate free radicals. So that is why you are having so many names. What you can see, iron initially transporting from transferrin, hepcidin, ferritin. So someone is there to take care of this iron. So it should not be left alone, because it can generate free radical. This reaction where iron can produce free radical, this reaction is called as Fenton reaction. This reaction, what we call this? We call this Fenton's reaction. So remember, iron can generate free radical, and this reaction, what we call this? Fenton's reaction. So iron should not be left alone. Am I clear, guys? So this is what we see. We see iron should not be left alone because it can generate free radical by a reaction called Fenton's reaction. Am I clear? If I say, what will be clinical feature in iron deficiency? What patient can develop? What are the symptoms? So what symptom patient can develop? So first thing I am writing, patient can develop general feature of anemia. Patient can develop general feature of anemia. So what are the general feature of anemia? Same general feature: fatigue, pallor, pain, claudication, giddiness, dizziness, right? Weakness, tachycardia, palpitation. These are general. SOB, shortness of breath. These are general symptoms. So patient will develop general symptom of anemia. All these general symptoms. But along with this, there are some special features. So if I say first special feature that patient can develop, there will be chillosis. You will see there will be chillosis or chilitis. There will be inflammation and dryness in the lip. Patient can develop inflammation or dryness in the lip. There will be inflammation in oral cavity. That is what we call, at the angles of oral cavity, we call this angular stomatitis. So there can be lip dryness, lip cracking. There will be angular stomatitis, inflammation. Patient can develop, in iron deficiency, you will see patient can develop spooning of nail. This question came in this attempt. This question came recently. There can be spooning of nail. Nails will become like a spoon. there will be spoon shaped nails. Spoon shaped nails is called koilonychia. There will be spooning of nail, we call this koilonychia. Clear? There will be spooning of nail, we call this koilonychia, right? And if I say sometime patient can also complain of pica. Sometime patient can complain of pica. So what is pica? Understand this. This is important. Pica means whenever patient is having iron deficiency, body start craving for iron. Body start craving for iron means person start eating non-nutritive things. Means आप कुछ भी खाना चालू कर देते हो. So it is nothing if I say it is eating non-nutritive things. Like मिट्टी खाते हो, chalk, slate pencil, mud. Many females, many males, they still consume this. Like I recently had a patient, she was 55-year-old and she is daily eating batti. Batti means slate pencil. Like in childhood, what we write in slate, we write with that white color, that is batti or slate pencil. So person start eating non-nutritive things, chalk, mud, slate pencil, etc. because there is body craving of iron. So understand this. Pica, if you see, there are two type of common pica. So most common pica that is seen in India, and most common pica that is seen in developed country, or I can say cold countries. So see, इंडिया में गर्मी ज़्यादा है, मिट्टी ज़्यादा है. So most common pica is person will eat mud. मिट्टी खाते हैं लोग, right? Like I am having a niece, my sister's daughter. She is just 3-year-old, but she eat a lot of mud. So most common pica is mud. We call this geophagia. So remember, इंडियन ज़मीन से जुड़े होते हैं, ज़मीन की चीज़ें खाते हैं. इन फॉरेन कंट्री मिट्टी नहीं होती, क्या होती है, सड़कों पे क्या होती है, बर्फ होती है. इन फॉरेन कंट्रीज दे हैव आइस इन द रोड, सो दे ईट आइस. These children in the foreign country, they will pick up ice from the road and they'll eat ice. That is most common pica. In developed countries will be ice. Am I clear? In developed country it will be ice. So if I say, based on this, you should know what are the causes of iron deficiency. What are the causes of iron deficiency? So what you have to remember, these features. Along with this, you should remember the causes of iron deficiency. Causes of iron deficiency anemia. So see, one by one we will write the causes. So I can say patient can develop iron deficiency anemia if you are not taking sufficient iron in diet. So that is dietary deficiency. So first cause will be dietary deficiency. First cause will be dietary deficiency. Dietary deficiency means you are not taking proper diet, you are not taking iron in your diet. That is dietary deficiency. If I say second cause of iron deficiency will be you are taking good diet, but your body is having some malabsorption disease that is not causing iron absorption, means there is decreased iron absorption. Second means there is decreased iron absorption, means your body is not having enough iron absorption. Now why your body is not having enough iron absorption? The reason is it can be due to some malabsorption condition. There is some problem in your duodenum. Iron absorption is primarily occurring where in duodenum. So there is some problem in the duodenum. You are having ulcers in the duodenum. You are having duodenitis. You are having some worm infestation. You are having celiac sprue. So you are having any condition that's affecting your iron absorption. Clear? So if I say there can be decreased iron absorption like malabsorption syndrome, or I can say like duodenum infection. Duodenum infection. Any infection of duodenum. Okay, if I say third cause of iron deficiency means this can occur whenever there is more iron requirement, but you are not taking iron as per requirement. That is there is increase in iron demand or increase in iron requirement. So remember, there is more iron demand in children, there is more iron demand in pregnancy, there is more iron demand where in lactation. So in children, in pregnancy, in lactation, there is more iron demand, right? A fourth cause, I can say, fourth cause means, suppose there is a person who is having iron deficiency anemia, he is eating healthy, he is not having any malabsorption, there is no infection, then why still is having iron deficiency? There is a acute or chronic blood loss. Acute or chronic blood loss. So understand this. Acute or chronic blood loss means, suppose acute blood loss means you are driving a car and you met an accident, there is blood loss. That is, it can be due to RTA or trauma, road traffic accident trauma. उसमें क्या हो गया? Blood loss हो गया. Chronic blood loss you can see in many conditions, like you can see chronic blood loss in peptic ulcers. Peptic ulcer, you can see chronic blood loss. Chronic blood loss you can see chronic blood loss in colon cancer. Colon cancer. Chronic blood loss can also occur due to infection of a hookworm. Hookworm infection. So remember this hookworm infection, it's a microbiology overlap with medicine. So that hookworm is called as Encyclostoma duodenale. Encyclostoma duodenale, remember it is hookworm. So this is one parasite that you remember, Encyclostoma duodenale, also called as hookworm. Hookworm. So Encyclostoma duodenale can also cause blood loss and it can lead to iron deficiency. Am I clear? It can lead to iron deficiency. So these are the causes, symptoms I told you. Now I'll tell you how you will approach a patient. So what will be your as a doctor duty? So what are the tests you will recommend and how you will approach this patient? So diagnosis. A 30-year-old patient came to you with pallor, complaint of fatigue, palpitation, shortness of breath. So first test that you will do, tell me the answer. What test you will recommend? Now you will tell me the answer. Which test you will recommend? First test, if you are suspecting anemia, what will be the first test? Dharmesh? Yes, CBC. Very good. First test you will recommend is CBC. So first test you will recommend is CBC. CBC. Now Chirag, tell me what you will see in CBC. What you will see in CBC? In CBC you will see hemoglobin is less. Clear? Hemoglobin will decrease. What else will decrease? MCV will decrease. Clear? In CBC hemoglobin will decrease, MCV will decrease. Right? MCV is less than 80. Yes, very good. It is less than 80. Now what else? You understood it is Sheetal. It is somebody from Sheetal. But if I say a child is coming to you. A child is coming to you with these features. Then remember, you should also think it can be. In Sheetal I told you. In Sheetal what I told you? SITAL. Sideroblastic iron deficiency, thalassemia, anemia of chronic disease and lead poisoning. So see, lead poisoning is rare, sideroblastic is rare. These three are common. Anemia of chronic disease, this patient will have history of some disease like history of rheumatoid arthritis, history of SLE, some chronic inflammation. So that is ruled out. So understand this, in young age you have two differential. You have two differential means if a question is coming of baby, mostly in practice mostly answer is iron deficiency. Clear? In practice mostly you will see patient they will have iron deficiency, but understand sometime a child can come or some patient can also come with thalassemia. So what we do is we do a simple basic calculation. You will see MCV of a patient and divide this MCV by RBC count. Till now you are not offering any other test. Understand this. MCV divide is MCV by RBC count. RBC count. If you see values are coming less than 13 or value may come more than 13. So values are less than 13 means values are low. Values are more than 13 means values are increased. Clear? Values are more than 13 means values are increased. So understand this, values are low. Low values are seen in thalassemia. And values are increased. Increased values means more than 13 is seen in iron deficiency anemia. So understand this, a good doctor will do this, a good physician will do this, because he is getting an idea, maybe it can be thalassemia, maybe it can be iron deficiency anemia. So understand this, if I say low, values are low, L for low, so you can see thalassemia is having L, and I for increased, I for iron deficiency anemia. So what you can notice, this is what I just told you now. We call this Mentzer index. We call this as Mentzer index. So what is Mentzer index? Understand this. Mentzer index is nothing, it is MCV divided by RBC count. If values are low, thalassemia, values are more, iron deficiency anemia. So I'll tell you, this is like why it is important. Like I had a patient, I was taking a class in Jaipur. This was a female patient, 18-year-old. She 19-year-old. She was taking treatment of anemia. So doctor were giving her iron tablet, iron supplements, right? But when I calculated Mentzer index, her Mentzer index came out to be 10.5. It means she was a case of, then we go for further investigation, that is hemoglobin electrophoresis. It was noted she was having thalassemia intermedia. And in thalassemia intermedia, if you give iron, there is no role. She will never have, she said she is taking these medications, iron supplement from past 4 years. So understand that sometimes reports can be abnormal, but remember, by doing simple calculation, you can save the patient. So see, CBC, पहले CBC कराओ, CBC में क्या calculate करना है? What you should calculate? Mentzer index. Mentzer index. Am I clear? If values are low, thalassemia. If values are more, iron deficiency anemia. Clear? Is it clear? Okay, next, if I say next test, tell me the answer. Karthik, tell me next test what you will do. अगला टेस्ट क्या करोगे CBC के बाद? What you will do? We can go for a peripheral blood smear. You can go for a peripheral blood smear. We also call this GBP. We can say peripheral blood smear or GBP. Means you will tell the pathologist will read GBP for you. So what you will see in peripheral blood smear, in iron deficiency anemia, you will see microcyte. Microcyte means small RBCs. You will see microcyte. Sometimes you will see pencil shaped cell. Pencil shaped cells, and you will see anisocytosis. Yes, we can call this blood smear, Karthik, we can call this blood smear, we can call peripheral blood smear, or we can call gross blood picture, GBP. You can see anisocytosis, and you can say poikilocytosis. I told you before, anisocytosis, poikilocytosis means it is a different shape and size. So what will increase? Red cell distribution width will increase. Because of this, what will increase? Red cell distribution width will increase. Clear? Red cell distribution width will increase. Okay. Now understand this. Some doctors then later on, they go for iron study. I'll tell you what is iron study. So why I am putting iron study? Now you should be asking me, sir, why you are doing peripheral smear? You could have gone for iron study before. Iron study is expensive. Remember, in India, we should treat the patient because we have a lot of poor patients. And these tests are sometimes not available free of cost in government hospital. You need to send this sample to private labs which are very expensive. So understand this. Third thing, you will go for iron study. Because iron study, it is expensive. It will cost near about 2000 rupees to patient. So peripheral blood smear is free of cost in government hospital. Even in private hospital, it's cheaper. So in iron study, you will see some values. So see, in iron study, you will see serum iron. Serum iron. Serum iron means iron deficiency anemia. Then tell me the answer. Serum iron will decrease or increase? Iron deficiency, so serum iron will definitely decrease. Clear? Serum iron will definitely decrease. If I say serum ferritin, what I told you, ferritin is reflection of your store form. Ferritin is reflection of your store form. So remember, store form will also decrease, because sometime when you are deficiency, first body will utilize the store. Once stores are decreased, then you get the symptoms. So store form will decrease. And always remember, in our discussion, I will tell you, ferritin is inversely proportional to TIBC. Ferritin अगर बढ़ेगा, TIBC कम होगा, ferritin कम होगा, TIBC बढ़ेगा. So if I say TIBC will increase. Clear? TIBC will increase. Is it clear? TIBC will increase. TIBC will increase. If I say sometime, they will also ask you transferrin saturation or percent saturation. Transferrin saturation. So remember, this will also decrease. So what you have to remember, 3 value in iron study, and remember, TIBC is increased, all others are decreased. Only TIBC is increased, others are decreased. Total iron binding capacity is increased. All others are decreased. So later on, I will try to confuse you, because these are the questions which they ask in exam. So TIBC is increased. Clear? TIBC increased. If I say what else you can notice, I told you before, you can see anisopoikilocytosis. So you will see RDW is increased, red cell distribution width will increase. Now understand one more thing. Try to understand this. If I say a patient is having iron deficiency. Iron deficiency means hemoglobin. Hemoglobin is made up of heme plus globin. If I say hemoglobin is made up of heme plus globin, globin is nothing. Globin is amino acid. Globin is your amino acid side chain. And if I say heme is made up of your iron plus protoporphyrin. Heme is made up of iron, protoporphyrin. Now see, body is having less iron, so iron is less. Iron is less. Iron is less. It means this protoporphyrin is freely available. Protoporphyrin is freely available because body is having less iron. So free protoporphyrin, generally it is bound with iron, but now it's available freely. So we call this increase free erythroprotoporphyrin. Increase free erythroprotoporphyrin. So erythroprotoporphyrin will increase. FEP. So these are the values you should remember. RDW, FEP will increase. So if I say in iron deficiency, remember what is important. What is increased, that remember. Remember those things, what is increased, others are decreased. Serum iron decrease, ferritin decrease. Right? TIBC is increased, RDW is increased, and free erythroprotoporphyrin is increased. This is your free erythroprotoporphyrin level. Okay, now understand. There is a syndrome called Plummer-Vinson syndrome. There is a syndrome called Plummer-Vinson syndrome. This is important because they ask MCQ with this syndrome. Plummer-Vinson syndrome, understand guys what it is. We also call this Patterson-Brown-Kelly syndrome. Patterson-Brown-Kelly syndrome. Patterson-Brown-Kelly syndrome. So this syndrome is a syndrome that is mainly seen in female. So if I say about this syndrome is seen in females. And these females, they usually have iron deficiency anemia, IDA. In their esophagus, so this is suppose esophagus, in their esophagus, these females are having constrictions. These are web-like constriction. We call them esophageal web. Esophageal web. And because of this constriction or web-like formation in esophagus, they will develop dysphagia. They will have difficulty in swallowing or pain in swallowing, dysphagia. Right? So you will see this is seen in females. Female is having iron deficiency anemia, and this female will also have inflammation of tongue. Inflammation of tongue is called glossitis. So understand this. Based on this, I will form a question. A 30-year-old female is having palpitation, pallor, tachycardia, shortness of breath, dysphagia for solids, glossitis. What is the diagnosis? So this is your Patterson-Brown-Kelly syndrome. This is your Patterson-Brown-Kelly syndrome. Am I clear? Patterson-Brown-Kelly syndrome. So remember, this is important. They have asked a clinical case. They have formulated a question. They have made a question with this. Plummer-Wilson syndrome or Patterson-Brown-Kelly syndrome. Am I clear? So you diagnose the disease. Now it's time to treat this. So if I say treatment of iron deficiency. Treatment of iron deficiency anemia. So depending on the hemoglobin levels, you should treat the patient. So let me say a patient is having hemoglobin values in the range of 9 to 13. Like if I say female 9 to 12 or if I say male 9 to 13. Right? Indian females 9 to 11. Clear? So hemoglobin values, let me say write this because 13 is normal. So I can say in females 9, 10, 11. So understand this. In females, what we say, it is Indian females till 11 is also normal. So if I say hemoglobin is the range of 9 to 13, or I can say for male 9 to 13, for female it will be 9 to 11. If I say hemoglobin values are 7 to 9, or I can say hemoglobin values are less than 7. So this is how we treat the patient. You have a patient, her hemoglobin value is 9 to 13. How you will treat? We'll try to give oral iron. Oral iron supplementation. In this scenario, hemoglobin values are 7 to 9. We give parenteral iron. Parenteral means we can give iron in the form of IV or IM iron. Parenteral iron means injectable form. Less than 7. Which iron you will give in which form? Try to answer, guys. Which you will give? Less than 7. Ravi, try to answer. So IV generally we are giving where? IV parenteral iron in which form? 7 to 9. In less than 7 what we give? Remember, less than 7, it is indication of blood transfusion. Now you will give blood to the patient. Because understand this, if you treat this with medication, it will take 3 to 6 months. With IV iron, it will take at least 10-15 days. So less than 7 is indication of blood transfusion. Am I clear? Less than 7 is indication of blood transfusion. Okay, so see, there are certain factors that increase iron absorption. Acetic acid, heme iron reducing agent, and if I say the fourth one will be your ascorbate acid or ascorbic acid or vitamin C. Fourth one will be your ascorbic acid. Ascorbic acid, or I can use the word citrate. So remember, acidic pH, heme ion, reducing agent and citrate, they will increase ion absorption. Alkaline pH, phytate, tannins, oxalate, they will decrease ion absorption. They will decrease ion absorption. So there is a common question that patient will ask you when you are doing a practice in India, like this tablet, if you are giving iron tablet, I should take this tablet with milk or with water. So remember, nowhere in narration it is written like this tablet you should take with milk. Always we should take tablet with water, right? But remember, this tablet should never be taken. So if I say iron tablet or iron capsule, you should never be taken with milk or tea. So if you are taking milk tea or coffee, milk or milk will decrease ion absorption. Milk will decrease ion absorption. If I say what you can use instead, you can use nimbu pani or lime water. You can use lime water, that is, remember, lime water or vitamin C. Vitamin C increase ion absorption. So like if you see my prescription, whenever I am having a case of iron deficiency anemia in my practice, I always add a tablet LIMC. So suppose if I am giving a patient iron supplementation, so how I will write? I will write iron ascorbate or iron tablet twice a day with tablet LIMC. LIMC means vitamin C twice a day. Why? Because vitamin C will increase iron absorption. Am I clear? So tell your patient ये iron की गोली कैसे लेनी है? नींबू पानी से लेनी है, lime water. Am I clear? This you should take with lime water. Clear, guys? Okay, now you have these values in front of you. I'll ask you a question. This you don't have to write this, just tell me the answer. Who will tell me? In iron deficiency anemia, serum ferritin will increase or decrease? Serum ferritin increase or decrease? Store form. Tell me the answer, guys. Store form of iron will increase or decrease? Serum ferritin will decrease. Okay, serum iron increase or decrease? Serum iron will decrease. TIBC. I told you ferritin is inversely proportional to TIBC. So TIBC will increase, right? And this transferrin saturation will also decrease. So remember, in iron study only TIBC will increase. Am I clear? Only TIBC will increase. So mainly here they confuse student, and trust me, by the end of our discussion, I'll make you a master in this thing. Here only student get confused. Other things are simple. Other things are easy in iron deficiency. Okay, treatment I told you we can give oral supplementation like ferrous sulfate, ferrous fumarate, ferrous gluconate or ferrous ascorbate. This is my favorite, but I prescribe is ferrous ascorbate because it's already having ascorbic acid. So these are oral iron formulation. We have ferrous sulfate, ferrous fumarate, ferrous gluconate, ferrous ascorbate. Or we can give IV iron like iron sucrose, iron carboxymaltose or iron dextran. Iron dextran is something that is commonly used. Iron dextran. Right? So understand this. It will take near about 8 to 12 weeks. 8 to 12 weeks means about 3 months. It is approximately 3 months. It's a deficiency. It will not treat in one day. So if by oral supplementation, it will take at least minimum 3 months. Am I clear? It will take minimum 3 months. Is it clear? So this is about your iron deficiency anemia. Any doubt if you are having, you can ask. Any doubt you can having, you can ask. Okay, suppose if I say the last thing here, what I can say is, suppose if you see a patient with iron deficiency anemia, what start you notice like patient first thing what is decreases your serum ferritin. So earliest to decrease serum ferritin. So let me just ask the question once again, try to understand this. Iron absorption occur in duodenum. If I say transporting form is transferrin, if I say stored form is ferritin. First to decrease, if I say earliest to decrease is serum ferritin. Earliest to be decreased is serum ferritin, right? Earliest parameter to decrease serum ferritin. What else is increased? RDW and free erythroprotoporphyrin levels are increased. Free erythroprotoporphyrin levels are increased. Am I clear? Free erythroprotoporphyrin levels are increased. Any doubt in this? Is it clear? So this is about your iron deficiency anemia. Okay, coming to the next anemia, that is sideroblastic anemia. Sideroblastic anemia. Sideroblastic anemia. So understand this. Sideroblastic anemia, remember, it is like iron overloaded state. So body will have iron overload. This body is having a lot of iron. Body is having a lot of iron, but this iron cannot be utilized properly. You cannot utilize this iron. So body is having a lot of iron, but you cannot utilize this iron. So if I say sideroblastic anemia, what are the causes? Cause of sideroblastic anemia, if I say first cause, it can occur since birth. It can occur since birth means congenitally it can be due to deficiency of an enzyme called aminolevulinic acid synthase. It can be due to deficiency of an enzyme called aminolevulinic acid synthase. So either there is deficiency of this enzyme, ALA synthase, right? Or it can occur, this is congenital cause. Okay, understand this. This enzyme we need for heme metabolic pathway, this enzyme is deficient, or it can occur because of some acquired cause. Some acquired cause, like it can be due to B6 deficiency. B6 is your pyridoxine. It can be due to pyridoxine deficiency. So B6 deficiency is not that common. Understand, B6 deficiency is not that common. So those patients who are having TB, who develop TB, they are taking a drug called isoniazid. So remember, it can occur because of isoniazid toxicity. It can occur after isoniazid toxicity, right? If you say this sideroblastic anemia, this is nothing, it is also occurring due to lead poisoning. So lead poisoning is basically nothing. Lead poisoning is an example of sideroblastic anemia. Lead poisoning is an example of sideroblastic anemia, because this lead poisoning will inactivate an enzyme called ferrochelatase. So understand this. Sideroblastic anemia, what you have to remember for MCQ point of view is pyridoxine and isoniazid. These two are important. It can occur because of pyridoxine deficiency or isoniazid toxicity. Isoniazid toxicity. Clear? So it is like an iron overloaded state, means body is having too much iron. So when you suspect the sideroblastic anemia, whenever you suspect sideroblastic anemia, how you will investigate the patient? So understand this. Patient will have same features. Features will be same. Because it's microcytic hypochromic anemia, patient will have same features, those same clinical features. So I am not writing the features. So how you will approach, that is important. Diagnosis. So first thing you will do a CBC. CBC will have, tell me the answer. What you will see in the CBC? Reducing agent means there are certain things which act as iron reducing factor, right? So these are some chemicals that we use in making medications. Okay, you will see CBC, you will see hemoglobin is decreased, definitely hemoglobin is decreased. Okay, tell me MCV. I will write the value, you will tell me the answer. MCV. MCV will also decrease. Clear? MCV will also decrease. Then immediately what you will do? You will go for peripheral blood smear. So guys, I am writing in short PBS. PBS is peripheral blood smear. In peripheral blood smear, what you will see? You will see, notice something in the peripheral blood smear, you will see basophilic stippling. You will see basophilic or basophilia. We call this basophilic stippling. in the peripheral smear you will see a ring, cells, they will form a ring. This is called ringed sideroblast. You will see ringed sideroblast. You will see ringed sideroblast. A ring, they will form a ring, we call this ring sideroblast, right? So you can see, if I can show you, these are basophilic stippling. They are loaded with basophils, so we call this basophilic stippling. And this is, they are forming a ring. So can you see this ring? This is the ring. What we call this? We call this ringed sideroblast, right? And sometime you will see calcium containing bodies. This calcium containing bodies, remember, they are not seen always, they are seen sometime. We call them Papanemer bodies. Papanemer body. But these things are not seen in practice sometime, because they are not in all patients, but they ask as MCQ. So remember, MCQ is basophilic stippling, MCQ is Papanemer body. These two are MCQs, two MCQs that came in exam, right? And I told you lead poisoning is nothing. Lead poisoning is nothing. It is a type of sideroblastic anemia. It is a type of sideroblastic anemia. It is nothing. It's a type of sideroblastic anemia. So basically, it is iron overloaded state. Body is having too much iron, but that iron cannot be utilized. There is no proper utilization of that iron, right? So in sideroblastic anemia, what you will see, there is a lot of iron, but this iron cannot be utilized. So if I say, sometime if I ask you an MCQ, what are the features of lead poisoning? So remember, in lead poisoning, so lead poisoning is a common topic, important topic that they ask in exam. So what are the features of lead poisoning? So remember, in lead poisoning, patient will develop anemia. Which anemia? This anemia is called sideroblastic anemia. In lead poisoning, patient will develop sideroblastic anemia. Patient will develop in peripheral smear, what I told you, basophilic stippling. There will be basophilic stippling. Means services will be loaded with basophils. There will be blue line in gum. This blue line is called Burtonian line. This is your forensic medicine question. You can notice patient can develop blue lines in gum. We call this Burtonian line. Patient with lead poisoning, they will complain of colicky pain. Colicky pain means patient will complain, I am having strong pain, like stone pain, colicky pain. Patient of lead poisoning will develop constipation. Patient of lead poisoning will develop constipation. They will develop drop. They will develop drop means there will be neuropathy, so they can develop wrist drop. They can develop wrist drop and they can develop foot drop. There can be wrist drop or there can be foot drop. So lead poisoning patient can develop wrist drop and foot drop. Later on, these patient can develop encephalopathy. Encephalopathy. And these patients in future they can have infertility. Infertility means they become, both male and female can become infertile. So there will be fertility issues. So why I am teaching this topic? Understand this because it's very important. They ask MCQ related to lead poisoning, basophilic stiffening, Burtonian line, drop, wrist drop and foot drop. Clear? So the features of lead poisoning you can remember by a simple mnemonic, that is A, B, C, D, E. So A for anemia, B for two things, Burtonian line and basophilic stiffening, C for colicky pain, C for constipation, D for drop, E for encephalopathy, F for fertility issue. So clinical feature of lead poisoning you can remember by A, B, C, D, E, F. A, B, C, D, E, F. Am I clear? You can remember by A, B, C, D, E, F. Is it clear? A, B, C, D, E, F. Is it clear? So basically what happens in sideroblastic anemia, we have a lot of iron. We have a lot of iron in every form, but this iron cannot be utilized because we don't have enzyme. So understand this, here generally iron study is not needed because lead poisoning patient will give you some history. But MCQ they ask you to confuse this, so I'll come to this. So first thing is, these are MCQ based thing, but if I say clinical practice what is important, in practice what is important is constipation. So if I say for me the most important thing is constipation, because why? Tell me the answer why. Most of the poisoning they will present with diarrhea. ज़्यादातर poisoning में क्या होता है? Diarrhea होता है. इसमें क्या है? Constipation है. This poisoning is presenting to you with constipation. So remember, that's why constipation is important in practice, but MCQ wise it's not important at all. Is it clear? Okay, if you can recall a little bit of anatomy, then tell me the answer. Guys, try to answer. Anatomy याद करो थोड़ी सी. Foot drop किस nerve injury से होता है? Foot drop is due to damage to which nerve? Foot drop is due to damage to which nerve? Give your input. Try to answer. Foot drop is due to? Yes, common peroneal nerve. Very good. If I say common peroneal nerve, and if I ask you wrist drop is due to damage to which nerve? These are straight away anatomy based MCQ. Okay, try to answer. Wrist drop. But गलतियाँ कहाँ होती हैं? Where we make mistake? We make mistake in easy thing. Right? There are mistake in easy things. So why nobody's answering? It's an easy question. Try to answer. Wrist drop is due to. So wrist drop is due to radial nerve. Am I clear? It is due to radial nerve. So understand this. Although we will not do iron testing in this case, but you should know the values. What values you will see in sideroblastic anemia in iron testing. So understand this. In sideroblastic anemia, we don't do this in practice, but what is the value in, if I say it is iron overloaded state? Iron overloaded state means, what about serum ferritin? What about serum ferritin? What about serum iron? Right? And what about TIBC? So these three things basically you should remember. Iron overloaded state means everything is more. Everything is more means serum ferritin is more, serum iron is more, and I told you ferritin is inversely proportional to TIBC, so TIBC will reduce. Simple. Iron overloaded state means ferritin is more, serum iron is more, and TIBC is decreased. Clear? TIBC is decreased. Am I clear? TIBC is decreased. So if I say the third type of anemia, just I want to finish this topic. So the third type of anemia I am writing here, that is your AOCD. AOCD is anemia of chronic disease. Anemia of chronic disease. So this is due to some chronic inflammation. So guys, try to understand this anemia, it's very important. So it is due to patient will have a chronic inflammation. So generally this will not be a children, it will be an adult. Like it will be an adult, means 30-year-old, 40, 50, 60. It will be adult, it will never be children. So you will see there is chronic inflammation. So whenever you are having chronic inflammation, you know main cells are macrophage. Right? So whenever you see chronic inflammation, because of chronic inflammation, what you will see your bone marrow is affected. There will be some effect to your bone marrow. Hematopoiesis is reduced. Right? Hematopoiesis is decreased means there is less hematopoiesis or less erythropoiesis. There is decreased erythropoiesis, there is decreased action of erythropoietin. But chronic inflammation, remember, chronic inflammation, it will also produce some macrophage. Chronic inflammation will also produce some macrophage. Chronic inflammation will produce some macrophage. And this macrophage, understand this macrophage, with the help of some protein called macrophage, especially in the liver. And I told you in the liver we have a protein called hepcidin. In the liver we have a protein called hepcidin. So remember this hepcidin protein and macrophage, what they will do, they will trap all the iron. So macrophage, what they will do, they will trap all iron. and lock it. And lock it. Lock it means they will put a lock on this. So understand this. So initially you will notice patient is having macrophage, they will trap all the iron. So patient will have, there is decreased iron, that is microcyte hypochromic. So initially you will see microcytic hypochromic anemia. Initially you will see microcytic hypochromic anemia, right? And later on you will notice there will be decreased erythropoietin, so you will see normocytic normochromic anemia. So what is my message here is, anemia of chronic disease can be microcytic hypochromic or it can be normocytic normochromic. It can be both. Is it clear? It can be both. So basically what you have to remember here is the principal iron regulator, that is called hepcidin. So there is locking of iron. So understand this. Let me give you an example. Suppose this is your liver, right? So all the iron is going into store. So why we store the things? We store the things so that we can utilize. So that's why we store the thing. But what happened here is, suppose you are a shopkeeper owner, you are storing the things, then suddenly government is imposing lockdown. Government ने क्या लगा दिया? Lock लगा दिया. There's a lockdown. You cannot use this. There's a lock, right? And whatever goods are coming, whatever iron is coming, suppose if you give iron to this patient, again this iron will not be utilized, this iron will be going to store. So whatever iron you will give, that will go to store. So understand this, store form will increase. Store form will increase. Store form is what? What is store form? Ferritin. So ferritin will increase. Store form will increase, right? But we cannot utilize the iron. We cannot utilize that iron, means transporting from our serum iron. If I say serum iron is decreased, and I told you ferritin is inversely proportional to TIBC. So TIBC will decrease. Am I clear, guys? TIBC will decrease, right? Okay, so understand the statement of sideroblastic anemia. If it is a congenital due to deficiency of ALA synthase, you cannot do anything. If it is due to vitamin B6 deficiency, then we should give pyridoxine. Is it clear? So generally we give pyridoxine to the patient. So now understand this. What I want you to remember for your life is, just I will try to compare three things which I taught till now. I told you 3 parameters and 3 diseases. So if I say first disease, I told you that was iron deficiency anemia. A second disease which I told you, that was sideroblastic anemia. Am I right? And third disease which I told you, that was your anemia of chronic disease. Simple. Am I clear? I told you these parameters, these diseases, and I want you to compare these parameters, and I want you to draw this. First, listen to me very carefully. Just don't blink and see the screen. I told you 3 parameters. The first parameter was serum iron. First parameter was your serum iron. Second parameter is ferritin or serum ferritin. And I told you ferritin is reflection of your store. And third parameter is your TIBC. So we need to compare these 3 things. Look at the screen, try to understand this. Very, very important. If I say iron deficiency anemia, tell me what about serum iron? Serum iron is decreased. Simple. Serum iron is decreased. I told you earliest to decrease. Store form is also decreased. And what I told you, ferritin is inversely proportional to TIBC. So TIBC will increase. Now see, remember my word for your lifelong basis. Sideroblastic anemia is iron toxic, iron overloaded state. Iron overloaded state means serum iron is more. So ferritin is also more. And what I told you, ferritin is inversely proportional to, this I will make again, ferritin is inversely proportional to TIBC. Ferritin is inversely proportional to TIBC. So TIBC will decrease. Simple. Now see, anemia of chronic disease. So here first thing I will not write iron. Here first thing I will write all the iron is being trapped in the store. There is a lockdown. Lockdown means you are having a lot. Suppose if I am having a shop. Suppose I am having a shop of mobile phone. I am having a lot of mobile. But because of lockdown I cannot sell that mobile. So understand this, there is a anemia of chronic disease means there will be a lot of store form. A lot of store form, and what I told you, store form. Ferritin is inversely proportional to TIBC. Right? But in the blood there is deficiency. In the blood there is deficiency means in the blood serum iron is decreased. Clear? So understand this. What you should remember here is they ask question like this. Low TIBC is seen in. Try to answer. Your exam question, low TIBC is seen in. Low TIBC is seen in sideroblastic and anemia of chronic disease. If I ask you low TIBC with increased serum iron. Low TIBC with increased serum iron. AOCD. If I say low TIBC with decreased serum iron. Low TIBC with increased serum iron, sideroblastic. Low TIBC with decreased serum iron, AOCD. Clear? So here this type of question they want you to solve. So this is very, very important. If it is, am I clear with this? Am I clear with this? So I want you to remember this for your lifelong basis. This is very, very important because here this is only the one thing that students are confused in hematology. And if you know this, then no question is difficult. Trust me, all other questions are simple. So see once again, I am drawing this once again. Iron deficiency anemia, serum iron is reduced. In iron deficiency anemia, what I just told, serum iron is reduced. Ferritin store form is also reduced. It is, in fact, it is first to decrease. And ferritin is inversely proportional to TIBC, so TIBC will increase. Sideroblastic anemia, iron overload. Serum iron is more. More serum iron means more ferritin. So ferritin is also more. Ferritin is inversely proportional to TIBC. TIBC will decrease. Anemia of chronic disease. Anemia of chronic disease. If I say serum iron, let me focus serum iron. More iron is trapped in the store. So store form is more. Store form is more means TIBC will reduce. TIBC is reduced. And if I say there is less form in the blood, so serum iron is reduced. So this is what you have to remember. Simple. So try to redraw this with your own hand once or twice. Then when I show you the questions, then you will notice there are a lot of questions which you can answer just by looking at this. So any doubt? So this is the first section of microcytic anemia that we have discussed. So any doubt if you are having, let me know.